we are living some big lies. To a certain extent, intelligent public discourse depends on us telling the truth, and what the science does is it gives us access to the truth. What we do with marijuana and its authorization is not a medical process. What we do with marijuana and its authorization is make a substance whose strength we don't know, whose impact on an individual we don't understand, available to people who are suffering. The good news is we're helping the suffering of people who are suffering. But the bad news is it is not a medical process. And that's where using the medical process to provide a pathway for people who are suffering is, I think, problematic, because it asks physicians to do something that they really aren't specifically trained to do. I think we have to stand on the science and really be clear about the science. So we have to, sort of own that there are some associations between adolescent use and drug addiction, and create social policy that minimizes that, or at least mitigates it. That's something we have to own. And then I think we have to own that the evidence supporting marijuana as a medical process is pretty thin, and if we're going to continue its use as a medical, in a medical way, we ought to commit ourselves to doing the research that's necessary to determine whether it's medical or not. If one legalized, then the need to create a medical process where there isn't yet the science seems much less, and that seems like a rational approach. I worry about the wink and nod process that now exists, that, it's Schedule I, nobody's supposed to mess with it, but a bunch of states are, and nobody's enforcing it. I would rather have us look at it in the face and say, let's find a way to do the research we need to do, and let's find a way to design a social policy that works both at the federal and the state level, that recognizes the difficulty of, perfect control, that owns the adverse outcomes because they are clearly there for some people. I think that kind of coherent policy development is important if people are going to have confidence in their government and our policies. It's pretty clear to me that our social policy around marijuana has been a dismal failure. You can still buy, I'm told, marijuana in every boys' room or girls' room in every high school in the state. And that's a big issue. We are, according to the evidence, we have more marijuana use in Rhode Island than any other state in the country, including Colorado, though the survey was before Colorado formally legalized. We have real use, and there's really good evidence now that shows a dose-response relationship between adolescent use and 5 different poor outcomes related to adolescence. So I'm not sure I have them all, but high school graduation rate, college graduation rate, drug addiction, suicide and depression are all directly related to the frequency of use by adolescents. And we have to own that. That is not a joke in the setting of a state where we lost 238 Rhode Islanders from drug overdose. We know that 80% of people who die of drug overdose got started on prescription drugs. So we have to own the prescription drug contribution. And then we have to look really seriously at medical marijuana itself. One of the hard things from my perspective, being here at the department, was, I think it's sometimes considered a success of the last 4 years that we implemented the Compassion Center program and got 3 compassion centers up and running. We did what the legislature charged us with doing, and did it, I think, faithfully and without conflict, which was a good thing. But truth be told, in that process, I looked at the medical evidence supporting medical marijuana per se, and I was actually surprised that the medical evidence suggesting that the real evidence suggesting that marijuana is medical is thin to none. What we see when we look at marijuana is that it probably has impact on symptom control. It helps people who are very sick feel better, and that's a good thing. So from a compassionate perspective, it's good that people have access to what it is they need to feel comfortable. But alcohol also is effective at symptom control. We know, physicians know, that alcohol is probably one of the world's great cough suppressants, and can be very useful from time to time. But marijuana and alcohol clearly have addiction potential, and we have to look at that as we design social policy. I think we gotta own this problem as a state and as a nation. This isn't somebody else, and this isn't happening someplace else to somebody else. This is all of us, and that means that it's prescribers, it's dispensers, it's the whole world of advertising that wants to convince us all that life gets better with a pill. We have to look at how our market and how our market works is affecting the fabric of our lives. And this is one way it really is affecting it. The number I can't get past is that 80% of people who will die of prescription or die of a drug overdose death started on prescription medicine, which means it's, and nobody meant to do that, but that means that prescribers need to be really careful how much they prescribe, when they prescribe. We all need to be careful about checking the prescription monitoring program. Is it onerous? It is, and that's terrible. But more terrible is 238 deaths and probably 10 to 20,000 drug-addicted Rhode Islanders. That is, that has a huge drag on the economy. It has a huge impact on the lives of families, and it's something we have unintentionally created together. I had colleagues who were very disappointed who are nurse practitioners and PAs, when the best reading of the law suggested that they weren't, according to the law, authorized to themselves authorize medical marijuana authorizations. That was a real struggle internally. And it was fired by our lawyers, not by our position. As I've said, medical marijuana, we haven't been convinced that it's medical. I haven't been convinced that it's a fundamentally medical process. So who gets to authorize turned into be, kind of an arm wrestling match based on the way the law was written. I spent a huge amount of time personally trying to argue with the attorneys that everybody who could practice at the level of primary care ought to be able to authorize. I wasn't successful, and it was a heartbreak because I think that kind of proved to be divisive among colleagues who ought to be working and thinking and rowing together. And for that, I'm still sorry that people felt disrespected.